Hello, everyone. My name is Ori Winfheimer. I'm a radiologist. I've been a radiologist for 20 years, and I'd like to introduce the coming day. Welcome to everyone to the AIMed Imaging Conference in the radiology track. Coming up in our first session, we have a session about use cases, both in the teleradiology setting and in the hospital setting with regard to radiology. Following that, we're going to have a panel discussion, how best to use the data science and incorporate it into your practice. And towards the end of the track, we're going to have an open forum where all the different chairs will get together and discuss all the information we've learned over the course of the day. Just a bit about myself. I'm a radiologist for over 20 years. I opened in teleradiology practice many years ago. And in the last few years have joined the medical innovation in radiology, which is artificial intelligence. Gotten very involved with Zebra Medical Vision, and now I'm currently the Chief Medical Officer and Head of Product Strategy at Zebra Medical Vision. And I can give you a little bit from my experience. Having entered the field from teleradiology and in artificial intelligence, I was very enamored by the use case of triage, intracranial hemorrhage, pulmonary embolism, different products that are out there in the market. And that seemed a very nice fit for artificial intelligence to be introduced into the radiology market. Ability to identify more urgent cases and present them to the top of the list for radiologists to get to them faster. And that's certainly a very worthwhile use case, and I'm sure you're going to hear about that soon with one of our speakers. Over time, though, we found at Zebra Medical Vision a different use case that we're currently focusing on that we are very, very excited about. And that's the use case of population health. Identifying chronic medical conditions for patients that are often undiagnosed, even though they're present in the data, seems to be a really beneficial direction for artificial intelligence. There's a lot of information radiologists are presented to on the imaging, and while we're all required to document what's on the imaging, a lot of the more chronic conditions tend to go unreported. Things like atherosclerotic plaques, coronary calcium, vertebral body compression fractures have all been documented in the literature and in day-to-day practice to go underreported in radiology imaging. Whereas these patients, if they could be identified at an earlier stage of their conditions, by highlighting those findings on the radiology report, we can direct these patients to their appropriate medical care at an earlier phase of their chronic condition and hopefully improve patient well-being and their long-term survival, as well as decrease cost to the system, because treating a patient's chronic condition at an earlier stage is much more cost effective. So I'll give you an example on vertebral body compression fractures, which is the first use case we decided to explore in population health. About 50% of vertebral body compression fractures, which are typically chronic and asymptomatic, go unreported in radiology imaging on the chest and abdomen CT scans. By identifying these fractures and highlighting them, these patients get directed to osteoporosis screening and care. And there are about 1 million hip fractures in the United States alone per year, and many more throughout the world. Identifying these patients who have osteoporosis at the stage where they don't have a major osteoporotic fracture, but a minor one, and getting them the appropriate behavioral modification as well as pharmacological treatment, we can hope to reduce the number of hip fractures out there in the population and really can affect individual patients' long-term well-being. So that's our concept in population health. We're very excited by this direction. We have other products coming along, both in coronary calcium and others, to really highlight these chronic medical conditions and get the patient's treatment at the earlier phase of their conditions. So that's where we like to focus our attention at Zebra Medical Imaging. We're very excited about this direction. There are certainly other use cases in artificial intelligence, such as triage we'll hear about soon, and productivity, making radiologists more productive by getting that additional help in using artificial intelligence. But we're very, very proud of the direction that we're taking. We're seeing a lot of excitement in the both radiology world, but in the primary care physician world, as well as medical risk holders and payers. And so that's where we'd like to be leading in this field. But we look forward to hearing the next speakers and hear other perspectives. Always exciting to hear from many, many different people, many, many different perspectives. And I'd like to introduce to you the moderator for the current session, Dr. Shah Islam, who's going to be moderating the next session with you guys. Hope you enjoy.
Thanks, Uri, for that introduction. My name is Dr. Shah Islam. I'm an academic interventional neuroradiologist with an interest in AI and medical imaging. It's my pleasure to moderate this session, which will be focused on the successful implementation of AI in teleradiology and other other radiology departments. We've got a fantastic lineup of speakers. Just to put things into context, it's no secret that currently in the UK we're facing a massive workforce crisis within radiology. It's predicted that at the current retention rates, we'll have a 45% deficit in the workforce by 2025. And really, there's a huge reliance now on teleradiology companies to provide imaging services on the reporting side. So the market is really primed to feel the impact of AI. So without further ado, I'd like to welcome Dr. Shaista Miraj, who's a consultant radiologist at Royal Bolton NHS Trust, and she's a consultant radiologist, but also in charge of AI evaluation. So Shaista, please, if you could take to the stage, thank you so much in advance.
Right, thank you very much. So I'm just going to share my screen. And there we are. Okay. Hello, everyone. Thank you very much for having me. I'm going to share what we have learned at Bolton Hospital. So for any AI implementation to be successful, we need a clearly defined use case. Having AI just for the sake of it won't work. It might work for the AI company selling it, but not for you. So at Bolton Hospital, we were already exploring AI tools supporting the diagnosis, and the pandemic accelerated the process. And we had this AI solution at the start of April when cases were building up and there was workforce shortage due to sickness shielding and redeployments. And chest X-ray emerged as a primary diagnostic tool to rapidly assess and triage patients. That's when we deployed this AI tool to analyze chest X-rays in COVID-19 patients. So what are the gains? For any AI radiology deployment, we can ask, what are we getting from it? So from a radiologist's perspective, a good AI solution will save time and do the tasks which are time consuming. It can prioritize our work and highlight potentially positive cases. It helps us to pick up findings that can potentially be missed. For clinicians, it should produce quick and accurate reports. For patients, it would be good to have quick treatment plans, and the hospital would benefit from having faster patient pathways and maximum efficiency in resource utilization. So pre-deployment, these are the points to consider, and this is a lot of work. So we need to carefully select AI provider with a good track record and peer-reviewed publications. They should be adaptable to accommodate the needs of radiologists and must align with hospitals' policies and vision. At this stage, it's useful to refer to the principles and code of conduct by Department of Health and Social Care. You need to have full engagement and support from governance, IT, and procurement. Communicate with all the users, including radiologists and clinicians. Talk to them, email them, send them demonstration videos and user guide, and give them time to absorb it and ask questions. Have safety measures in place and educate the users on how to record and raise any concerns. Be very clear on what customer support AI company will provide you. Have a structure on how you would scale the deployment and get meaningful information from it to show its impacts on the clinical pathways. You need a dedicated AI team with defined roles. You need to design an evaluation methodology to check product is performing as it should be. There are no patient safety issues, the results are accurate, and what is the user experience. Make sure there is no data protection issues and the equipment and PACS is working well. Ideally, you should also have an external independent evaluation, but we're not there yet. The evaluation can be retrospective and prospective, and one way to have prospective evaluation could be to combine it with post-market surveillance studies. There will be regular communication and meetings with AI company involving the IT department, PACS team, the PACS provider, and the evaluation team. And these will be of high frequency initially as there will be teething problems. Having regular AI meetings is vital to see the progress. There will be ongoing learning and you need to quickly adapt. Have deadlines so you keep the momentum going after the initial excitement is over. Keep communicating with the users and get their feedback. There will be regular information sharing and updates with IT and PACS team, so organize your time for that. You need collaborative work with clinicians to see how it's affecting the patient pathways. Regularly audit your work and present the findings to all involved. It's important to know what is working. From our experience, we found that for radiologists, they stated that having an AI analysis before the formal report is useful for clinicians. And there are no serious discrepancies. Clinicians found the tool was easy to use, and they were happy that it shows correct labeling of the chest x-rays, and then wanted to have similar AI tools in the future, which was very encouraging to know. Hospital is benefiting as the patient management is faster. The turnaround time for chest x-ray report is now less than 3 minutes, when normally it could be 2 to 10 days. The AI company is benefiting from having a live deployment experience in the NHS, the first of its kind. So what isn't working? Some radiologists found the AI solution is intrusive and slowing down the reporting. Some clinicians thought that they really don't need it when they can comfortably read chest x-rays on their own, and some thought it is overcalling. For patients, we did make a poster explaining the AI software, reassuring that it is used as a decision aid tool for faster treatment plans, although we strongly think that engaging patients on a wider scale is important. For AI company, the challenges are navigating through ever-changing regulatory landscape, especially post-Brexit, and relative lack of clearly defined guidelines. Our AI solution was on-premise, and accessing data for the AI company was difficult, as none of our data leaves the hospital server, but obviously there are AI solutions which are cloud-based. Coming to the challenges, there were so many challenges we faced, but we're learning as we go along, still learning. Managing change when it is disruptive is tricky, so you need to be very mindful of that. Many clinicians still find it hard to trust the accuracy of the algorithms and how these were trained. The culture is changing, but it is still not favorable for AI technologies, and I strongly think that the AI developers need to closely work with the end users, including the patients. Having a comprehensive pre-deployment briefing of the radiologists and clinicians is extremely important. No AI deployment would be successful if the users do not know why we have this AI tool and how to use it. And AI companies here also have the responsibility to design user information in a simple and digestible way. AI is new, and not many health professionals know how it works. It's important to increase AI literacy among the clinicians and patients. I don't have to say much on funding. It's about the money as well. Who is paying for it, and what are we getting for our money? Most of the organizations have no AI workforce, and those who have also struggle to build and maintain a skilled and dedicated team. There needs to be clearly defined training pathways. When I designed the evaluation methodology here at my place, I had little idea, and it was a steep learning curve for me. It's only recently that work has started at national level to develop an evaluation structure. There will be heavy involvement by PACS team pre and post deployment. And in our experience, we struggled because at the same time, we were setting up home reporting workstations, and later on we changed our PACS provider. There will be IT and hardware requirements, which need to be carefully explored before the deployment. And considerations should be given to what extra processing power is needed for future updates and PMS studies. I cannot stress more on colleagues' engagement, as you cannot work alone after you've deployed. You need clinicians to feedback to you and assess the impact on clinical pathways. You need feedback from radiologists, and without their help, you cannot evaluate the AI tool. And be mindful that not everyone will share the same passion and enthusiasm about AI as you might do. And there will be times when you might think you're not getting anywhere. There's a greater need to have designated external bodies who can provide you with guidelines and support throughout the process of deployment and evaluation. Having post-market surveillance studies is important to see any performance shift in the algorithms, and again, close working partnership with AI companies required. Some overseas AI providers might not be familiar with the regulatory requirements of a particular country, and it can delay surveillance studies. So it is important to ask if AI provider has a country representative. Evaluating the AI provider's compliance on regulatory, technical, and operational ground is important. Finally, it is important to have a health economic analysis of the AI tool and determine the return on investment. This will also help in business case for future procurements. Role of the hospital, the organization. For any solution to be successfully deployed and running, you need hospital board and executives to be supporting you from the very start. The organizations need to formalize a process for AI deployments, have an AI workforce with funding and resources, and plan to train the staff. They need to consider transformative effects of AI technology in terms of possible de-skilling of the staff and how to manage downtime. They need to engage patients and educate them on AI and what benefits it can have. And organizations need to work with all stakeholders and the industry and share best practice. This is a little bit about our work at Bolton. Luckily, we won few awards, and we are working with NHSX AI Lab. I've shared my evaluation work with them, and I participate in their focus group discussions. Thank you very much. Sorry, Shah, I think you're on mute.
Sorry, thanks, Shasta, for that talk. Many important lessons learned. And now it's my pleasure to introduce our second speaker, who is a real tour de force within the teleradiology sector, Dr. Samir Shah. He's been in senior leadership positions throughout his career in teleradiology. The past decade, he's been involved at Nighthawk Radiology, Virtual Radiologic, and currently at Radiology Partners, where he's currently VP of Clinical Operations and President of Daytime Remote Radiology. Thanks, Samir.
Thanks so much, Shah. I'll try to keep my comments brief, and I also will share my screen. Give you one moment. Got a bit of an hourglass here, sorry. Okay, there we go. Shah, can you see my screen okay?
I can see it great.
All right, great. So going along with Dr. Miraj's comments on the hospital side, I wanted to talk a little bit about AI in teleradiology and my experience, and hopefully it'll give a little bit of an insight to everybody else. My first slide is always the same one. It just keeps me humble. Remember number 3, most common Google search for radiologists. So again, Shah gave my background. I've been in teleradiology for about 13 years at the senior medical leadership level. So I wanted to kind of discuss what I saw as future needs and future tech in teleradiology and what's going to be happening. We've all seen lists like this. Who's on call from Tuesday, Monday through Friday, 3 to 5 p.m., and then who's covering on the weekends, et cetera, et cetera. You know, we are so busy in teleradiology that doing this sort of thing and trying to figure out who to call and getting somebody else on the line and somebody else is covering because they're on vacation, that's all going to go away. You know, as we see different AI use cases, I definitely see more and more automation of critical reports and critical findings. It's definitely being automated more and more. Another thing I see is we all work with work lists as radiologists. You know, everybody sees a work list and kind of decides what's their next case and picks it, and it opens up. I see it all going away with AI and teleradiology. You know, really, it's already started, but generally the algorithms will pick the best case. So it'll find the person that's credentialed, find the person that's not busy, find the person that has the right licenses, find the person that has the right specialty and has the freest time on their work list to do X, Y, or Z case appropriately and in the appropriate time. So that's all going to go away. You don't need a work list anymore if the AI algorithm can help you with it. And finally, one more comment that I wanted to make was we still practice in a way very similar to what we did 20 years ago. There was a recent Twitter conversation that I saw where folks were describing common misstatements by voice recognition. And I thought to myself, I had a similar conversation in, residency 20 years ago. And not much has changed in that arena. It's going to change with AI. There's going to be vastly different ways of communicating and reporting. So what do I see as future reporting? So many things that we are asked to do and that we may not necessarily have been trained with are going to become absolutely routine parts of reporting that are filled in, put into the report automatically by AI. With stroke imaging, the Alberta aspect scoring scale is becoming more and more common, but most radiologists haven't been trained with this. So they want to, implement it, but they don't want to delay, because any moments that you delay reporting a stroke study is time is brain. So the same goes along with trauma grading. The trauma surgeons, especially in the US, need a grade for every laceration of the liver, any organ laceration. They need it to maintain their trauma certification as a level 1 trauma center, et cetera, et cetera. It's required by the American College of Surgeons, et cetera, et cetera. But we haven't been trained like that to report it. We see bleeding, we see a laceration, we just want to get that report out. What if it was all done automatically? And what if documentation that Dr. Shah spoke to the trauma surgeon about this report was automatically documented? Imagine the time savings that every radiologist would earn. What about ultrasound measurements? We have a system where an ultrasound tech is reporting a case. They measure something on the screen, then they take that measurement and they write it on a worksheet. Then they fax or copy that worksheet into the PACS, and then the radiologist dictates that measurement. I mean, there's 3 opportunities for an error. Just from the screen to the transcribed ultrasound worksheet to the radiologist dictating that number. 3 opportunities for error, and it happens. All of us as practicing radiologists know that it happens. So there's no need for that. We have technology that can easily take a measurement from a screen, a digital measurement, and put it into our digital dictation system. Key images in reports, I think that's a concept that's about 20 years behind. Again, our PACS is digital, our reports are digital, they can be incorporated easily. And imagine the value, not only for the clinician, to be able to see the mass that the radiologist is describing, see the measurements, see the size of an intraparenchymal hemorrhage, but also to the patient. Let's face it, patients are becoming consumers more and more. And to give them the value of actually being able to see something on their images is incredibly valuable. So what do I use in teleradiology today? I have a number of widgets. I use a computer vision technology from AI I use a impression generation technology from a company called RadAI. I use a report generator that actually puts my report into a structured format from another organization. And then my own organization developed its own AI so that we have standardized best practice recommendations for any entity that we're following. And so, that all of these live as widgets on my system. That's today. So, what are we going to see in the future? Those widgets will all be incorporated into the reading system seamlessly. That's what's heading on. But the very fact that I have 4 or 5 AI tools today shows you that AI is here. It's not coming, it's already here. It's just that we have tremendous opportunity in the next decade and a half or so to really develop the radiology report of the future. All those key images automatically imported. Anything you measure, hyperlinked. Somebody just has to click on it and they'll see the measurement digitally. All the elements of the report, the technique, the history, the comparison, all of that is automatically imported. Anything that is a critical finding, a hemothorax, a intracranial hemorrhage, automatically notified and identified. The entire text of the report should be generated by AI in the style that I typically dictate in, right? The whole thing. All that has to happen is that I just have to look at the report, look at the images, and say, yes, that's exactly what I would have said. Literally all the findings in the impression, everything is generated with AI technology. That's what I see happening in 15 years. It's dramatic and it's maybe ridiculous, but it's the natural progression if we look at things. What about masses, oncology? All of that change in time of a lesion would be calculated and measured with standard reporting lexicon, RECIST criteria, what have you, staging of cancers, everything would be automated. We need this stuff because right now we do it all manually, and all radiologists know this is a tremendous burden. And as Dr. Islam mentioned, we have a shortage in the US as well as in, around the world, as well as the UK. So, how will studies be managed? Not only just reporting, but studies. You have certain studies that only a few of your radiologists, teleradiologists read. Maybe it's a cardiac case, maybe it's a pediatric case. You have it coming from multiple sites, right, onto a radiologist system, onto their work list. All different sites, all different types of studies. But there's another couple of axes also. Oh, Dr. Shah reads cardiac nukes, but he's on at midnight, but he's not on at 1 a.m. It'll have to be Dr. Jones that reads cardiac, right? Because Dr. Smith does not read cardiac imaging, even though he's on at both those hours. It's really a couple of different axes here. So I see a complex tesseract. Basically, all of these things will be coordinated by AI. Who's on, who's going to get what image, and who's going to be able to read it timely. Okay, that was quick, and I am complete right now. Back to you, Sean.
Thanks so much, both of you, for your talks. So, Samir, you mentioned like you're using multiple AI technologies, right? Your current workflow process. The situation we're in now is that AI vendors are hitting us with multiple solutions. And so do you think there's going to be a bigger role to play for the RIS and PACS vendors for a more streamlined integration of multiple technologies so that for the end user, you have one interface?
I do. As Dr. Miraj mentioned, one of the things is that a lot of radiologists aren't familiar with AI. They need training. And if you have 15 widgets on your system, it's going to result in mass confusion and more error than actually assistance. And so without integration, it's going to be very, very difficult. These things take time. And I think one of her points was key. Radiologists are not familiar with AI right now. And it has to be seamless. It has to be super seamless because we've got thousands of images to review on each case.
Yeah, and Shaista, you mentioned that you're currently doing on-prem deployments. Generally, the technology sector would prefer to move to cloud-based solutions. Do you foresee, in the UK, we're very, our hands are tied by very tight data governance. Do you foresee a situation in the not too distant future where we will move to cloud-based solutions, especially considering most of the teleradiology players already moving to cloud?
Yes, it would be great to do that, but it's I can't answer that question how soon it's going to be, but that's the ultimate solution. But as I said before, some AI providers are from overseas. Even the home-based AI providers, they really it's only up when you get into that deployment and run it, then you will know what intricacies and what kind of complex regulatory and data protection requirements you have to fulfill. And it's such an intense communication between the AI providers and the governance department of the trust that it's just mind-boggling. It's not my area, but I have an idea what goes on in the background. And it's just, we need to sort this out. But again, AI is grown exponentially. But the things we had to do, we are lagging far behind, and we have a lot of catching up to do in all the fields, trusting it, giving it a chance, governing it, and looking at all the data protection aspects. So yeah, cloud-based ideal, but who knows when are we going to do that? But yes, that's ultimately we should aim for.
So like the three of us in this room, we're all practicing radiologists, and generally the hype of AI within radiology has always been on the clinical decision support side. But you mentioned this, Samir, like based on your opinions, do you actually think the bigger impact of AI in radiology will be in invisible AI, which basically upstream AI before all the processes that happen before we acquire images, or do you still think the bigger play will be in clinical decision support? Because my personal opinion is that image acquisition, scheduling, workflow management, critical finding dissemination is going to be huge. But what do you guys think?
Oh, it's a great question. And a lot of people ask about that because there's been so much emphasis on clinical decision support. In the US, it's actually hopefully to be kind of a stopgap to prevent so much imaging from being performed. We perform so much more imaging than the UK even, and we have MRI scanners in every community hospital, et cetera, et cetera. So it is very important, and it is an obvious use of AI. And but I agree with you that cat has been let out of the bag. The physicians that are trained today, they need imaging. It is the backbone of diagnosis for them. You know, it is more important than the physical exam, and it is necessary. We are the foundation of modern medicine. And so imaging is not going to slow down. And I agree. It would be best if there is a support, the key word being support. And AI would be great for that. Which study is the right study for this patient? Imaging is so complex. There's a million studies available now. Yes, help them on that end. But you are absolutely correct. The much more important management is to control that flow of information that's coming at that radiologist on all the different ways that we discussed, that we can do it on the back end, critical findings, et cetera, et cetera.
And
sorry, can I add? Yeah, absolutely agree on that. You know, they say the useful AI is boring AI. It's not a sexy AI that you see on the front. So absolutely, having this backlog in the NHS, it's extremely important to have AI working in the background, scheduling, predicting patients who would not arrive. As you said, Samir, that I came across a patient kind of knew that she's having so many CTs so frequently. So AI should be able to tell you what was the most recent scan that radiographers might overlook, and you might overlook betting the scans. It should tell you how much radiation this patient has had according to their age. So these are the things which shouldn't really be sitting there in the dark, and you overlook those important points. And a lot of work needs to be done at that level. So I agree, absolutely. Images, fine. Images are having those images and labeling and all that is good, but a lot of work needs to be done before that process.
Well, before we close out, I just want to say thank you again to both of you who've seen AI deployed within a single player market like the NHS from Shaisa's talk. And, you know, again, Dr. Shah, thank you so much for giving your insights into the teleradiology sector. From what I've read, the sector was worth about 8 billion in 2020, and by 2025 is predicted to reach about 22 billion. So we're going to see a huge throughput of imaging in the teleradiology sector, both in the UK.
And COVID may have accelerated that even more.
Yeah, COVID 100% accelerated both in the acute out of hours reporting, as well as clearing the huge swathes of backlogs that we're all facing on both sides of the pond. So thank you very much. I have no other questions. So guys, please enjoy your evenings and afternoons. I will be hosting a roundtable discussion on radiology AI imaging in about 8 minutes. Thank you so much.
Thanks for the opportunity.